Um, we're going to move to South Carolina now to hear from Wesley Wampler and Mirinda Gormley to talk about outreach in South Carolina, particularly in rural areas of South Carolina, and really bringing different parts of government agencies together to extend access to care and treatment for hepatitis C. Wes, Mirinda.
Good morning, everybody. I am Mirinda Gormley. I'm an epidemiologist at Prisma Health in South Carolina, and with me today is community paramedic Wes Wampler, who runs our CP-HCV iLink program. And today we're going to talk to you about pathways to the cure, mobile integrated healthcare transforming hepatitis C treatment through community care. So this project is possible through the front lines of communities in the United States or the FOCUS program, who provide the funding for our opt-out program that screens for hepatitis C virus and HIV in our emergency departments. I know a lot of you probably know about opt-out screening programs, but I'm just going to summarize here. If you step foot into my ED, we hand you a piece of paper that says that you will be screened for hepatitis C virus or HIV unless you elect to opt out. If you don't opt out, then we test you and we send your results to your MyChart app. If you are positive, one of our care coordinators contacts you and then tries to link you to care. And we find that we have a pretty good success rate with linking people to care. About 2 out of 3 of our patients are linked to an outpatient appointment. However, there is that 1/3 that even when they are linked to an appointment, they don't come or we can't get a hold of them. And so we really wanted to focus in on those hard to reach individuals. And so we started calling some of these individuals and just asking, why aren't you coming to treatment? And we found a couple common barriers. The first and foremost was transportation. Many of our individuals are very rural, and so a lot of them arrive to the emergency department by ambulance. They don't have a personal vehicle. Additionally, Uber and Lyft do not exist for these individuals. But even if we were able to get Uber and Lyft for most of them, some of them have a medical condition that impairs them from being able to take Uber and Lyft to receive an office-based treatment. Additionally, no health insurance is a huge barrier for many people because they feel that if they don't have health insurance, that they just can't get treatment because it's too expensive. Further, no cell phone or poor internet access keeps us from being able to do effective telehealth communication with these individuals and their homes, eliminating the possibility of doing a telehealth intervention. And finally, there are some other financial barriers. Many of these individuals are newly employed or employed at places that are not okay with them taking time off to travel to and from an office-based appointment. And so these are the main barriers that we wanted to address with the CP-HCV iLink program. This is a multidisciplinary program that brings together a community paramedic or a paramedic who does public health functions in the community with an infectious disease provider. They work together to do a physical examination and then a telemedicine visit with the patient in order to get them started on HCV treatment within their home. So I'm going to briefly go over our eligibility criteria. Patients have 3 ways that they can be entered into this program. First and foremost, when my care coordinator contacts somebody, if those individuals say that they have a barrier, any of the aforementioned barriers to attending those appointments, they are put into the CP-HCV iLink program. 2, if somebody is scheduled for one of our office-based appointments and they do not show up, we have the care coordinator follow up with them to see why and enroll them in the CP program if necessary. And finally, we have a couple people that come to the office-based appointments and then they just stop showing up, right? So we have the care coordinator contact them. She does a reassessment of their social determinants of health, and she determines whether or not any of those barriers are present and then links them into our program. So now that I've told you about the eligibility criteria and a little bit of the background, I am going to turn you over to the community paramedic that runs our program, Paramedic Wampler.
Hi, everybody. So after these patients are identified, our care coordinators, they schedule a telehealth appointment and with the community paramedic. We arrive on scene, we do a focused exam, we do a 12 lead if necessary, obviously vital signs. I'll touch on this in a little bit later, but we can do the fiber scan on scene. We obtain labs that are necessary, and then we coordinate the telehealth encounter with Dr. Rolfe, our primary infectious disease doc, or one of the nurse practitioners with our addiction medicine center. At the time that we visit with them, we get the paperwork submitted. If they're uninsured or underinsured, we do financial assistance through the hospital to get that worked out. We try to identify other social determinants of health that are limiting, including we'll help them apply for Medicaid if necessary. We will help them get their medications that they probably haven't been taking or not, they can't get acquired. We'll get food for them through different programs, do whatever is necessary for that. So at the end of the encounter, we'll get the labs that are ordered by Dr. Roth. We'll take them to the lab. And then if the patient has stable housing and the patient has somebody there that can sign for the medications, we'll get it delivered directly to their home. If they're not able to do that, if they are homeless, if they don't trust their neighbors, whatever it is, we can get the medicine shipped to the clinic, and then I will go pick up the medication and get it to them. At 4, 12, and 24 weeks, we'll go back, do follow-up labs. We'll check in with them, see how they're doing with their treatment, and address any other issues that have come up along the way. So here's kind of a timeline of what of how it works out. So patient is tested for HCV. Hopefully we get the results within a couple of days. The ILink coordinators hopefully will contact them within hopefully 10 days and set up an appointment for the telehealth encounter. We will arrive there. We will complete financial assistance. We'll get that. Usually it takes about 2 weeks, maybe a little bit less, to get the medication approved and get it out to them. At 4 weeks, we'll redraw labs to make sure the treatment's working for them. 12 weeks, we don't often get 12 weeks anymore. We used to at the beginning, but certainly at 24 weeks, we'll get the SVR labs. And then within 6.5 months of initiating or identifying the patient, they'll be cured. So this is kind of our numbers so far. Our paramedics, 1/5 of our patients are self-pay, and these patients, like I mentioned, that we'll do the paperwork necessary. We haven't had a single patient that we've had that has not gotten their medication. We will Medicaid is 40%, Medicare 20%, and then private other insurance is about 18%. So we've had 108 patients linked to the CP program. 3 of those patients, we had the appointment set up. I went to their door and they didn't answer, and then we weren't able to get in touch with them, so they were lost to contact. Of the 105 patients, 4 patients unfortunately passed away during treatment. 4 patients were discharged for loss of contact after the initial encounter for various reasons. Maybe they moved out of state or they just stopped answering the phone. There are 29 patients currently in treatment, or 27%, and then 68 patients we've cured, or 65%. This is the cost estimate for a community paramedic, including the hourly rate, including mileage, anticipated vehicle costs, the cost of supplies. This obviously does not cover the initial startup, onboarding, the initial cost of the vehicle, the equipment. That's a pretty hefty price. But afterwards, each patient, we've estimated about $278 per patient for the community paramedic to respond out and take care of that. This is our addiction medicine mobile clinic that we have that goes to 2 communities in the upstate. They are staffed with a nurse practitioner, a social worker, a peer support engagement provider, and then research providers. A lot of the patients that are here, they'll start out in the mobile clinic if they can make it to the mobile clinic, and then something comes up in their life that they can't continue coming to the mobile clinic, so then I will go out and see them. Or if there's resources at the mobile clinic that I can't help them out with, there's some stuff that the social worker or especially peer support can't help them out with, I will facilitate getting them to the mobile clinic to get that treatment or intervention. And then there's some other research opportunities that are available that we have personnel there for. This is one of the devices that we have just started to use. It's the FibroScan. This device is we're in its infancy. It's a non-invasive ultrasound procedure used to assess the health of the liver as far as stiffness and fat content. Liver biopsy obviously is the gold standard, but that's a lot of people can't get those liver biopsies, and there's a lot of side effects associated with them. The sensitivity and specificity of especially in the higher fibrosis stages are very high. And we're using this program. We've scanned 10 patients for the HCV island program, and also 2 patients in the mobile unit. We're still trying to finish up training, and we'll incorporate that more in the near future. This next device is the Cepheid point of care testing. We had just acquired this device, which has been a huge help. For those not familiar, this device will test the patient for the PCR by testing just a capillary blood, a very small amount of blood. It usually takes about 45 minutes for the patient for a positive to come up. It takes about an hour for a negative, and the quantitative range is as low as 10 international units per milliliter. The sensitivity and specificity of this test are about as high as you can get. And the advantage to this is that our regular lab, the Hep C RNA quant, requires a regular lab draw. We have to get it to a lab that's not Prisma. They run it for us. It takes 3 days to get back. It's a very costly lab. This device, we can get results within an hour, and which can kind of generate our treatment options and evaluate our treatment. And it's a very, very low cost. So we're still in its infancy. We just got this device this year and started using it. It's a great device that I think we're going to expand more the more we find ways to do that in the jail setting or what have you. But so why does this matter? This gentleman is William Westfield. He was one of our early patients back in 2021. I met him after he was found to have HCV through an unrelated ED visit. He had a huge distrust in the medical community. He was very hesitant to even let me in the door. After some talking through the door, he let me in. So his blood pressure initially was 200 over 100. We had the telehealth encounter. Labs were difficult. The Cepheid would have been nice in that case, but with that initial encounter, we were able to get him blood pressure meds. I went out and picked that up. We were able to set him up with transportation to see the addiction medicine specialist to get on Suboxone. I went back, I think, 3 or 4 times that week, 3 or 4 times the following week, and we had his blood pressure kind of under control. He had several other things that we had to help him out with, or I got the opportunity to help him out with, that were challenges for him. We got him cured of his Hep C, and I actually had the opportunity to go to California with him. It was his first and only flight out to California to discuss his case at a national conference. He has a truly heartbreaking story of what he's gone through. But one of the things that he said, it gave him more time to spend with his granddaughter. He said when he got home from work that he was tired. He didn't have enough energy to be with her. After we initiated treatment, he got cured. He spent every day with her. Unfortunately, I spoke at his funeral back in April of this past year. He passed away from a cardiac event, which was heartbreaking, but a wonderful guy. Which programs like this were, and like what you all are doing, were in place 15 years ago, because unfortunately, he had several years after he got treated, but he should have had more. I appreciate all you do, and can attest that there were many, many more individuals like Mr. Westfield that are given an opportunity for a more healthy and enjoyable life because of individuals like all of you. So I appreciate the opportunity, and we're gonna think you're gonna send a link for.
I have a link. Mr. Westfield did an excellent presentation for us for Fox News to talk about our program and how it helped. This is a really good example to circle back to what Rachel said about how you have to address multiple layers at once. And Paramedic Wampler and the other community paramedics that work with him are able to address HCV, and they're also able to connect them to treatment for primary care issues such as hypertension and opioid use disorder. So that is the wonderful benefit, and very cost effective. And that's the wonderful benefit of having this program using community paramedics. So thank you very much. We'll take your questions in the chat.
Thank you so much. I was tremendously energized when I heard about this at the Global Hepatitis Summit in Los Angeles back in March. I had never been familiar with a paramedic outreach such as the type that you have put in place in South Carolina. I think it was really very innovative and seems to be very well accepted. And just thank you so much for this new way of extending care for hepatitis C to this population.